today's talk is going to be about PMR and GCA. So we'll kind of go over those things, and towards the end, we'll do some board questions together, okay? So PMR, Polymyalgia Rheumatica, it's an inflammatory syndrome that's really characterized by pain and stiffness in the proximal muscle. So really the shoulder and kind of the hip area. There's really not much weakness. The ESR and CRP will be elevated, and it's typically symmetric for at least 2 weeks. They'll up to 50% will have constitutional symptoms. So fatigue is a very common one, low-grade fevers, weight loss, night sweats. The morning stiffness is pretty predominant. Usually in any of our inflammatory conditions, morning stiffness is a big sign of uncontrolled or untreated disease. So usually like over an hour is pretty abnormal. Obviously the rheumatoid factor and CCP antibodies are negative, so it's not suggestive of RA. Once they are put on steroids, they have a pretty rapid response in terms of the muscle symptoms within a week, and really want to exclude other diagnoses that can masquerade as it like rheumatoid arthritis. Typically PMR, it's the second most common autoimmune syndrome after rheumatoid arthritis, usually women more so than men. It's very, very, very rare to see it in someone less than 50 years old. So if it's someone less than that age with these symptoms, you really think of a different diagnosis than PMR. Most patients are 60 or older, and it's usually Caucasian patients. It's less common in other ethnicities. So here you have a little diagram of kind of which muscles are most involved in PMR. The shoulders are much more commonly involved versus like the neck and the pelvic girdle areas. Typically, it's not a very rapid onset. It's very subacute or kind of slow in onset over 2-3 months. There's something called a gelling phenomenon. So basically, it feels like when they're moving their joints, like their shoulders or knees, it's very stiff, and it feels like they're moving through gel. So like it's very hard to like push through. Nocturnal pain is a characteristic, and it'll wake them up at night. It's different than rheumatoid arthritis in that it's non-erosive, and they can develop inflammatory peripheral arthritis involving the hands, knees, wrists, sternoclavicular joints. Usually the poor predictors for PMR is if they're older, when they get diagnosed like 70 years or older. Females, they have a very high ESR to CRP ratio, and it doesn't normalize within a week of starting prednisone. Most patients can taper off the prednisone within 2 years, about 75% of them, and they'll be fine. But then, oftentimes we do see relapses in these patients, usually like months or years later. And then very few times there's like some patients who might need just low doses of prednisone, like 5 to 10 milligrams indefinitely because they keep relapsing. On the exam, if someone's coming in with, active PMR that's not been controlled for months, they don't look well. They're very tender and painful with active range of motion of their neck and shoulders. If it's been going on for a really long time, they can develop capsular contractures where they have limited passive range of motion when you're trying to assist them, and muscle atrophy because they're just not moving their shoulders. Strength testing is typically normal, but it can be limited due to their pain. And if they have that peripheral arthritis, and they'll have synovitis, so they'll have joint swelling and tenderness and warmth in the affected joints. In terms of labs, obviously the ESR, that's really going to be the one that's the most significantly elevated, and also the CRP. They can develop an anemia of chronic disease, other kind of inflammatory markers like their platelet counts are up, or gamma globulins on the SPEP. LFTs can be elevated too. But really the labs that should be normal are like the rheumatoid arthritis antibodies, the ANA, the muscle enzymes, that's a big one. That shouldn't be elevated in PMR. If this is elevated, then you start thinking of other things like rhabdo or myositis. Same thing with the UA, right? There shouldn't be any blood in the urine or myoglobin. if you did tap the joints, it should be inflammatory, so the white count should be over 2,000, and there shouldn't be any crystals, so it suggests like pseudogout or gout, and the culture should be negative to not indicate a septic joint. PMR and GCA, they overlap and they frequently occur together. In patients who have GCA, about 40 to 60% of them will also have PMR. It's kind of the opposite, vice versa. If they have PMR, GCA is not as common as the 40 to 60. It's like 15% or a little bit more. They did find that in 9% of patients with PMR, if you did a temporal artery biopsy, they would have temporal arteritis, even though they didn't have any clinical evidence of vasculitis. And if you did a PET scan in the PMR patients, 30% of them would have increased uptake in the aorta. So the question is, do they have some kind of subclinical aortitis? So the question is, are these two separate diseases, or are they just the same disease, but we've given them different names and labels, and the severity is really the only difference between the two. When you have a patient with PMR or GCA, you really need to think of other diagnoses too, right? So I would say the most common ones, obviously chronic pain or fibromyalgia, right? Their ESR should be normal. They'll have tenderness all over. Polymyositis is another big one, right? We talked about the CPK levels will be elevated in this, really proximal weakness without pain. The EMGs and nerve conduction studies are going to be the most helpful to help differentiate between those two. Cancer is a big one. If someone has cancer, that's undiagnosed, that can cause ESR levels to be very high too as well. Infections, another cause of that too. Rheumatoid arthritis, that's probably the highest on the differential to rule out when you have these kind of patients. In terms of treatment, obviously the first thing to start is steroids. We don't do really high doses of steroids. High doses to us is like 40 milligrams or higher. So these patients usually can get away with like starting at 20 milligrams or so. They'll have a very rapid response in their symptoms in terms of the movement and stiffness. And then we taper very slowly. So usually maybe every month you'll go down. And then as you get down lower and lower, you don't decrease it by the same amount every time. You kind of go slower. So once you get down to 10, you'll decrease it by usually like a milligram each time. The reason why we do this is very easy to flare as you're going down the prednisone. So you don't want to go too fast. And typically if they do flare, then we go back to the dose that they were on before, that they were doing well on. In those patients who do flare, then we start thinking about steroid sparing options. Obviously, prednisone has a lot of side effects with chronic use. Methotrexate is pretty commonly used. There have been some studies looking at tocilizumab as well, and that has been shown positive results. We typically do this also if they have any comorbidities that won't work well with steroids. So if they have poorly controlled diabetes or hypertension or osteoporosis, these would be good options too. Obviously, you want them to keep their muscle strength, so individualized exercise programs help with that. Really hasn't been any good evidence for TNF inhibitors or any herbal supplements for this condition. GCA goes by a lot of other names, most commonly temporal arteritis. This is the most common systemic vasculitis, up to 1% in the US. This is also the same age distribution, usually only affects people 50 and older. It's more common in females, and most commonly in Northern European descent. When they present, it's really important to take a good history and asking about where their headaches are. You want to know if they had a history of migraines and if the headaches are different from the migraines or if they're similar or not, and the location of it. Scalp tenderness or sensitivity, so if they're brushing their hair, if that's really sensitive to their scalp, that's one story you can ask about. Jaw claudication, that oftentimes gets confused with TMJ disorder. So claudication is really if they, if they're eating and it's not pain suddenly, but as they keep chewing, it just becomes more uncomfortable. So that's really the best way to ask about the claudication. Visual symptoms, right? So, diplopia, visual disturbances. Another one would be amaurosis fugax, where they describe like a black curtain coming down. That's probably the worst sign that you can pick up, and that's usually the worst predictor for developing blindness. And then also constitutional symptoms too as well. Upper extremity claudication, we'll kind of go into why, and that's usually with extracranial GCA. On the physical exam, they'll have tenderness of their scalp. If you feel on their temporal arteries, it'll be difficult to palpate. It'll be tender as well. We talked about the amaurosis, fugax, and diplopia, for loss of vision. So these patients should be seen by ophthalmology when they come in to evaluate for this. The blood pressure, if you check in both arms and the pulses too as well. So if they have vasculitis that's extracranial, that could explain if there's a big difference in the systolic blood pressure between the two arms. And you can also take for bruits in the carotid and subclavian vessels too as well. If GC is untreated, it can be pretty bad. They can lose their vision. So 15%, and that's due to ischemic optic neuritis. We say temporal artery, but it's really the posterior ciliary branches of the ophthalmic arteries that are involved in this vision loss. If they get treated with steroids, then the risk of blindness is less than 1%. So this is really important if you have someone that you have a suspicion for this, that you need to contact a specialist and start them on steroids right away. You can't wait a day or 2 days or 3 days. Mortality is pretty, there's increased risk of death about 3 times within 4 months of starting therapy, but that's usually due to strokes or MI. And like I said, if they have anything such as just impending vision loss, then you should not hold the treatment. If they're trying to get like a temporal artery biopsy, you should just go ahead and start the treatment. Usually the results won't be effective for a week or 2. In GCA, the vessels that can be involved, it can really be any medium or large size vessel. So like we were mentioning, it could be the subclavian or vertebral or carotid. And you'll see symptoms, involving, related to these vasculitis in these areas. Coronary arteries can cause chest pain. Pulmonary arteries is pretty rare. I haven't seen that yet. They probably have those at the NIH though. Extracranial GCA, the aorta is involved in 15 to 20%. They have been doing PET scans at the NIH to evaluate for large vessel involvement. And you'll see a subclinical aortic inflammation in 50 to 80% of patients, but it doesn't involve the intracranial vessels, and that's really because it lacks the internal elastic lamina invasive disorder. So here is an example of extracranial GCA. So here's an MRA, and as you can see where the arrows are, if you compare it to the other side, you do see some long tapering of the left axillary artery. This is in a PET scan that's demonstrating diffuse large vessel GCA. So here you can see that there's involvement of the aorta, also the subclavian and carotid as well too. In terms of workup, the ESR, right, that's going to be very high in most patients. You also see other signs of inflammation too as well. The temporal artery biopsy is pretty much the gold standard for diagnosis, but it's not always required to make the diagnosis if you have a very high suspicion based on everything else. The sensitivity of doing a unilateral biopsy is 87%, and if they have bilateral biopsies that are negative, then the negative predictive value is pretty high too, 91%. There are other imaging that can be done for temporal arteritis. So an ultrasound, what you'll see is what's called a halo sign. So you see wall thickening around it, and that specificity is pretty high too as well. And then also if you're looking for large vessel involvement, aortitis, then like we mentioned, that MRI or PET scan, those are the most commonly done. In terms of the ultrasound, it's very dependent on the person who's performing the ultrasound. in terms of the the reliability of the results too as well. So this is a pretty straightforward diagnostic algorithm for GCA on imaging and the biopsy too as well. So if you do have, if they do have symptoms and exam and labs that are concerning for GCA, and they have cranial signs and symptoms, and you see if you have the Doppler TA ultrasound available, yes or no. If not, then you can go to an MRA. And after that, then it's the biopsy. If they do have it, then you look for whether the halo sign or not. If they do, then you go ahead and treat SGCA. If not, then that's when you consider doing the temporal artery biopsy. If they have just extracranial or systemic symptoms only, then we talk about the large vessel imaging, and then based on those findings, if it is suggestive GCA, you treat it. If not, then you really consider a different diagnosis. So this is a the histopathology slide. So what you're looking at in terms of the arrows, the arrowheads is really showing the disruption of the internal elastic lamina, and then over here, these are showing the giant cells, as in for giant cell arteritis. So typically the findings that you would expect to see in GCA is that there's granulomatous inflammation in this area too as well, and then also these multinucleated giant cells. But giant cells really only occur in about 50% of the cases. So the name's a little misleading in that sense. Treatment. So these patients you'll treat with higher doses of steroids compared to PMR. So usually it's prednisone 1 mg per kg per day. So usually like 60 milligrams or so. And you'll do that until the hopefully the labs resolve and normalize. And this is a very slow long-term taper. It can be over 1 to 2 years. If they have impending vision loss, then you're much more aggressive. You'll pulse them, usually 1 gram a day for 3 days, and then oral prednisone after that. Low dose aspirin has been shown to reduce cardiovascular events and blindness, so patients should be started on that. And the same thing with the steroid-sparing options, methotrexate or tocilizumab. And those have been shown to be very effective. The biopsy, like we mentioned, you should not hold treatment. Try to get the biopsy within 7 days, and the steroid shouldn't affect the biopsy findings as long as it's done within 2 weeks of starting prednisone. So I put in 3 mix-up questions that we can go through together, and then kind of go through the reasoning too as well. So question 1, you have a 79-year-old guy who's coming in with 2 months of progressive malaise and weakness, aching bilateral shoulders and hips, and morning stiffness for 2 hours. He's noticed some aching in the jaw when chewing, new left-sided headaches. Last week he had diplopia for a minute, and hypertension. He takes hydrochlorothiazide. So his vital signs are normal. He's got some tenderness and slight swelling over the left temple, some painful limited range of motion of the hips and shoulders. His ESR is 85. So which of the following is the most appropriate initial management? I don't know if there's like a poll option here for people to choose answers. Maybe not. So the questions, the answer choices are CT head, low-dose aspirin, methotrexate, prednisone, or TA biopsy. Does anyone want to guess?
Would it be prednisone?
Yeah. So first thing, right, is treat them first, and then the workup will come afterwards, right? So this patient you would want to start on prednisone so that you can prevent any irreversible damage from the untreated disease. So okay. Question 2, 73-year-old woman is hospitalized for heart failure with progression over the past 2 weeks. She also has 6 weeks of arm aching, worse with lifting and reaching, hip aching, morning stiffness, fever, and malaise, no headache or jaw claudication. Temperature is 99.5. Blood pressure is normal, but the systolic is 16 less on the right arm. Pulse is 90. No rash, no temporal tenderness, She's got a brewery over the right supraclavicular fossa, right radial pulses reduced, diastolic decrescendo murmur in the upper right sternal border, bibasilar crackles, painful range of motion in the shoulder and the hips, no joint swelling. Echo shows that aortic valve regurg, normal leaflets, dilated aortic root, dilated left ventricle. So which of the following is the most likely diagnosis? I think you guys already know the answer: Kawasaki's, PN, subcranial GCA, Takayasu's. So obviously this is subcranial GCA or extracranial GCA. This is a patient who has symptoms of PMR, and they have involvement of the aorta with the aortitis, and that obviously manifests with the aortic root dilation, aortic regurg, and heart failure. The last question: 75-year-old female is evaluated for 2 weeks of gradually increasing pain in the shoulders and hips. The pain radiates down both arms to the elbows and down both hamstrings to the knees. No headache, jaw claudication, or vision changes. She was diagnosed with PMR 3 months ago. She started prednisone 15 milligrams a day with immediate and complete relief symptoms. Then it was weaned to 10 milligrams a day 2 months ago, then 8 milligrams a day a month ago. And she was asymptomatic until 2 weeks ago. So the current symptoms are just as bad as when she was first diagnosed. Her vitals are normal, blood pressure is identical in both arms, no temporal tenderness or induration, painful range of motion of shoulders and the hips. So which of the following is the most appropriate management? So something I had mentioned before, right? So it sounds like she's having a flare. And they've been tapering her prednisone down 15 to 10, okay, and then down to 8. She didn't really have a flare until 2 weeks ago, and that was after they went down to 8. So the question is, what would you increase the prednisone to? Would you go to 10, 30, 60, or would you go up to 20 and also add in methotrexate? And I think the most important thing is this is her first flare. Really, if you obviously I think it's overkill if you go to 30 or 60. Those are pretty high doses, and she was doing well on 10, right? So obviously the answer choices are between A and D. The question is, when do you add in the steroid sparing option? In this person, they only had 1 flare, and they're on like a low dose, low to medium dose of prednisone. So the right answer is A. If they are having frequent flares, then yeah, would consider adding the methotrexate. Obviously, methotrexate comes with its own, side effects and things like that you have to monitor for. So in this person, I would just go back to the 10, and you can go down. I would probably keep them there for a few months until things are back to normal, and then and like every month you probably go down by like 1 milligram each month, and then just making sure she's okay. So, and you also want to make sure that their ESR and CRP have normalized too before you start tapering down the steroids again.